For pediatric patients with liver cancers, and I'm just going to talk more focused on hepatoblastomas, there have been really nice improvements in the past with conventional chemotherapy, improving the outcome of these patients. And now when we look at all comers, about 80-85% of the patients are ultimately cured, which is really great news. But this does come at a price of several months of therapy that has acute and long-lasting toxicities. And, of course, there are patients who, despite all this, won't get cured. And, even more interestingly, there hasn't been really new drugs discovered the past several decades now. We are using the same kind of Cisplatin, Doxorubicin-based regimens that have been around for a long time. Of course, now field knows much better who to give more chemotherapy, who to give less. And so risk stratifications have been tremendously helpful on for example, to save some of the toxicities for certain groups that don't require that much. But one would hope that, in the 21st century, we can come up with drugs that are, more effective, ideally less toxic, and perhaps work faster, that we don't need to treat patients for a 6-month period or so. So my lab has been working on what we think could be an approach that fulfills all these criteria. We genetically engineer a specific subset of white blood cells called T cells to recognize and kill tumor cells. And we also insert another gene, or in the future even more genes, that make these cells expand and last longer in the patient. And so they can fight longer or prevent the recurrence of the tumor if needed.